I welcome you all for journal club of this month. First report is fetal therapy current scenario in India. It was published by Dr. Shagun Agarwal in Indian Journal of Practical Pediatrics in 2019 Jan and March edition. Okay. Good evening, everyone. As you all know, fetal therapy or treatment, the developing is an exciting treatment modality, and that provide opportunity to correct or ameliorate fetal disease state, thereby preventing the morbidity and mortality, and facilitate successful culmination of the pregnancy. It is very attractive modality, but it is still in its infancy. There are various methods which are used by routinely, but the surgical things are not that developed in India. So what are those things, and how far we have achieved in this specialty? We'll see in this topic. Okay. So since this method is a risky one, especially the surgical part, so International Fetal Medicine and Surgery Society has laid some guidelines which can be used to start the therapy. So what are those guidelines? First thing is, natural history of the disease should be at least or partly understood. The condition should be lethal or could result in severe morbidity if not treated in vitro. And the fetal intervention should be at least partly corrective, and the result should be compared favorably with those obtained following the postnatal treatment. So if these guidelines are met, then only we can give the fetal therapy or in utero therapy. So what are the types of fetal therapy? There are two types: medical therapy and surgical therapy. Medical therapy is widely used by many obstetricians, but surgical therapy is only available at few centers. Okay, so in medical therapy, common things like steroid for lung maturation, dexamethasone, as you all know, 4 doses, 6 milligram, 12 hours interval, 24 hours before the delivery, or betamethasone, 12 milligram, 24 hours apart. These drugs are known to enhance the fetal lung maturity and can be used to prevent the respiratory distress syndrome in patient where threatened preterm delivery is suspected, or where preterm delivery or preterm LSS is planned whenever there are other risk factors. Steroid is also known to prevent the intraventricular hemorrhage. So these therapy help in prevention of this intraventricular hemorrhage. Then some drugs like NSAIDs are known to prevent the polyhydramnias. It will decrease the amniotic fluid content. It will prevent and provide the symptomatic relief as well as prevent the complication. Drugs like Sulindac is found to be safer compared to other drugs, and 400 milligram per day for severe polyhydramnias causing maternal distress or threatened preterm labor, or in cases of monoamniotic twins to prevent the cord entanglement is used. In cases of fetal thyroid disorders, both hyperthyroidism and thyrotoxicosis, we can use the fetal therapy. In cases of fetal hypothyroidism, mother can be given thyroxine, or whenever more specialized thing, (150 to 600 microgram weekly) results in fetal euthyroid status. In cases of fetal thyrotoxicosis, treatment involves propylthiouracil to mother in doses of 100 to 600 milligram per day, which crosses transplacentally to the fetus and exert the therapeutic effect. In cases of congenital adrenal hyperplasia, we know this, that whenever there is a previous pregnancy with congenital adrenal hyperplasia, we start steroids whenever the pregnancy is planned, or at least by 6 to 8 weeks of gestation. And at the age of 11 to 12 weeks, fetal gender or disease status is confirmed by chorionic villus sampling and the target molecular testing. If we see if the fetus is unaffected or male, then the treatment is stopped, or else it is continued. If the fetus is female, then treatment is continued till the term. Okay. Some cardiac rhythm abnormalities also treated antenatally. Suppose if a child is presenting with severe tachycardia due to rhythm abnormalities and like SVT, digoxin can be given in cases of supraventricular tachycardia without high drops, because if a patient is having SVT, the child can develop congestive cardiac failure, and which can lead to high drops and fetal demise. So these things needs to be treated in the during the fetal in utero only. So digoxin can be given to the mother in a dose of 0.25 to 0.5 milligram per day. In cases where supraventricular tachycardia with high drops, the drugs like flecainamide can be used, and sotalol primarily used in atrial flutter without high drops. And refractory cases, we can use amiodarone or combination therapy during the pregnancy. With the use of these drugs, the conversion rate of sinus rhythm is seen in 15 to 90% of the cases, with lower percentage is observed in fetus with high drops. If high drops is developed, then the recovery rate are less. In cases of refractory cases and in fetus with high drops, rather than giving to the mother, direct instillation of the drug to the fetus by either by intraamniotic infusion or by intramuscular injections or intraperitoneal or intravascular administration is shown to be beneficial. There are some novel medical therapies which are still in study phases, or not much case reports has been done. In cases like congenital pulmonary airway malformation, where there is a fetal lung lesion, it is shown to be shown to respond to administration of maternal corticosteroid. A recent study, recent case series of 43 patients showed 82% reduction in the lesion size and 88% high drops resolution rate following the betamethasone intramuscular administration to the mother. Some rare fetal conditions like in cases of biotin deficiency, biotin can be given to the mother, vitamin B12 for fetal methylmalonic acidemia, and pyridoxine for pyridoxine dependent seizures. However, these treatments are still remain in experimental stage and awaits larger case studies. One of the most important thing which is practiced in tertiary level obstetric units, like intrauterine fetal blood transfusion, which is practiced since long in cases of RH incompatibilities. Here, presently management of RH hemolytic disease involves serial monitoring of middle cerebral artery peak systolic velocity for evidence of fetal anemia. That is, anemia requiring transfusion is defined by multiple of median more than 1.5, followed by ultrasound guided umbilical vein puncture for estimation of fetal hematocrit and subsequent infusion of packed PRBCs if hematocrit is less than 30. And again, the hematocrit is repeated after 15 to 20 days, and it is for subsequent blood PRBC transfusion can be given. PRBC which is given is O negative, which is cross matched with mother, and it is triple saline washed and can be given to the baby. And after delivery, immediately after delivery, baby is again exchange transfusion with O negative blood is done. Okay. After medical therapy, surgical therapy, the principle which are used whenever they go for surgical therapy are: the condition should be severe enough to warrant intervention. Prenatal intervention is associated with better prognosis compared to the postnatal treatment, and condition should not be severe enough to be irreversible already. So if these three conditions are there, then we can go for surgical therapy. So what are the methods by which surgical therapy can be done? First thing is open surgery. Open surgery can be used for treatment of congenital diaphragmatic hernia, congenital pulmonary airway malformation of the lung, myelomeningocele, sacrococcygeal teratoma. Here the direct incision is taken over the hysterectomy is done, and surgical repair is done. But this modality is not available in India. This is present only very few specialized centers in the world, and this carries high risk of mortality of both mother and baby, and high risk of chorioamnionitis and other complications. So this thing is not yet available in India. Okay. The other things like fetoscopic approach and ultrasound guided approach, yes, these are available in India. In fetoscopic approach, small caliber endoscope is placed by abdominal incision, and with that various procedures can be done. The most common thing which is done is laser ablation of the communicating vessel in twin-to-twin transfusion syndrome. Selective fetal reduction by ablating the feeding vessels, umbilical vessels of the baby. Intratracheal balloon insertion for diaphragmatic hernia. This is done, I think, even in Kolhapur also. Valvotomy for posterior urethral valves and amniotic bands. So these fetoscopic approaches are done in India. Very few centers are there, but still it can be done. And then ultrasound guided procedures. Even these procedures are done mainly in tertiary care obstetric centers, like placement of shunts for drainage of the obstructed bladder, that is vesico-amniotic shunt, and for draining the thoracic collections like pleural effusion, cystic lung lesion by thoraco-amniotic shunts. Radiofrequent ablation of the umbilical cord for fetal reduction. Valvuloplasty for obstructive cardiac outflow tract lesion, and intracardiac potassium chloride administration or cord occlusion for fetal reduction in multiple order pregnancy. So these things are done in India. Okay, so these are various fetal surgeries. For congenital diaphragmatic hernia, open surgery followed by closure of the diaphragmatic defect is can be done, but it is not available in India. Fetoscopic occlusion of the trachea using balloon leading to pulmonary inflation. This has shown to be beneficial by randomized controlled trials. Still, trials are going on. Lower urinary tract, in cases of lower urinary tract obstruction, vesico-amniotic shunt placement is being done, but the way it has variable results because of pre-existing renal damage. Cystoscopic posterior urethral valve ablation. This is under this thing is done, but still under study. This study is still requires further study. Neural tube defect. This is open surgery for closure of defect, which is not available in India. Twin transfusion. This fetoscopic selective laser fulguration, this is done at many centers. In cases of sacrococcygeal teratoma, again, open surgery is not available in India. Ablation or embolization of the feeding vessel, this is again in very few case reports are present. Okay. Similarly, there are other conditions like amniotic bands, which can be ablation can be done by fetoscope. In cases of fetus arcardia, selective feticide using either ultrasound or fetoscopic ablation can be done of feeding vessels to causing fetal demise. And in cases of high order pregnancy, similar feticide can be done. So these things can be done. In India, in medical therapies, intrauterine transfusion, NSAIDs for polyhydramnias are given. Drugs for treatment of arrhythmias, medical therapy can be given to the mother. Thyroid disorders are treated. And other things like amnio drainage or IVIG for intraperitoneal congenital heart blocks can be given. In cases of surgical therapies, fetoscopic laser twin-to-twin transfusion syndrome can be here ablation can be done. Fetal reduction can be done. Then in cases of lower urinary tract obstruction, shunting can be done, and thoracoamniotic shunting can be done. So these mainly these procedures are done in India. There are some novel therapies which are still in studies phases, like in utero stem cell therapy. This is both based on the premise that due to relative immunodeficiency state of the fetus, introduction of the stem cell may lead to better engraftment, and this can be used in subacute combined immunodeficiency syndrome. Then some studies are going on in animal studies are going on in utero gene therapy, where the target gene is introduced at the embryological or at the target organ level, but still these are in animals study phase. Okay, to conclude, the development of various fetal treatment strategies offer hope for in utero management of the fetal disorders, but long-term outcome of for many of these interventions need to be studied. There are also ethical concerns, especially with regards to the fetal surgical therapies, and the availability of the trained experts and centers offering this therapy, especially are very rare in India. So these limitations indicate that this field is still in its infancy, and there is a long way to go before this intervention translate to routine clinical practice. Thank you.
Amar, it was a nice presentation.
Okay, thanks.
Many of the things we also don't know. So, any questions from participants?
अजून सगळं डायजेस्ट व्हायला थोडा वेळ द्यायला पाहिजे.
हो हो हो, बराचशा सगळ्याच गोष्टी नवीन आहेत आपल्यासाठी.
ठीक आहे. निगंधी सर आलेत काय?
निगंधी सर आहेत की.
क्वेश्चन असतील तर मग प्रोसीड करूया.
Good evening, everyone.
Yeah, good evening.
Good evening, sir.
Good evening. Good that we don't, in orthopedics, we don't have any fatal things to be seen and treated intrauterine. So we can very well wait for the baby to come out. And We had just, I mean, if you have a couple of minutes, I can just tell about one case which I just recently saw. Uh, can I? Yeah.
Yeah, go ahead.
So this was
Yeah, go ahead.
uh, a pregnant female of around 18 weeks gestation, 17 weeks gestation with short femur. And when we measured, we did couple of ultrasounds with from experts from Kolhapur, and everyone was of opinion that there is a discrepancy in limb length on one side. So initially the measurements were the femur was short by zero point 0.3 centimeters, but subsequently as the child is growing, and now it has come to 25th week of gestation, and now the length is the difference is almost 1 centimeter now. So it's a dilemma for us that what advice we should give to these parents, because likely that this child is going to have a proximal focal femoral deficiency with or without hip dislocation is very, very high. And if that happens, then the prognosis is going to be very bad. And it's now almost 25 weeks already done. So medico-legally MTP also cannot be advised. So it's a real dilemma for me, and I have taken my a couple of friends' opinion, and we have decided that we'll just go ahead with the pregnancy and then see once the baby is out.
Really challenging this
Yeah. So
whether
clubfoot
to
and all
take the
things
risk.
we generally see long frequently, but this short femur syndromes or some knee dislocations and things are very difficult to counsel and to treat also once the baby is born. Shall I
How
just go ahead?
how parents react with this? Do they give consent if at all you happen to be, if you say that you might have to terminate the pregnancy
Yeah,
because you
but
don't know the
nowadays,
diagnosis.
yeah, we know the diagnosis, but now with the changed rules of termination, so you have to have at least 2 or 3 experts' opinion and before and then only you can advise for termination after this.
Exactly, because in that committee also pediatrician is included, so we need to
Yes,
know
yeah,
your opinion in such cases.
correct.
It's very
So
important.
yeah, occasionally we get these patients and we are really in dilemma, uh, and we do not have any guidelines for this
Yeah.
kind of syndromes.
Mm-hmm.
Hmm.
Okay.
Shall I just go ahead?
Yes, sure, sure.
Okay. So, so this is, can you see my screen?
Yes, sir.
Yeah. Uh, so I'll just quickly go through this paper. This is a very interesting paper, and some of the pictorial presentations I have put it just to make the paper a little more interesting, because this all paper contains only text. There are no pictures. So I thought I'll just add some more pictures to give a better illustration of the subject. So very often we see sequelae of this kind where the femoral head has already gone. There is a lot of shortening. The femur has bowed, and if we come across this, it's already late, and then this requires a lot of reconstruction and a lot of procedures. Child may have to undergo 3, 4, 5 procedures, to get his limb equal, to make his joint stable, and even after that there will be a lot of complications of that. So we want to basically avoid all these complications of septic arthritis and osteomyelitis, and thus this paper is very, very important. So another example of osteomyelitis of femur at presentation and subsequently at 1 month, and you can see that the femoral head is already destroyed. with deformity of the femur also. So coming back to the paper, so this is a paper from Italy. So very surprisingly, because most often we see papers from countries like USA or UK, but this is a paper from Ancona, Italy. This orthopedic department has studied this paper. So they have done systemic review of all the systemic reviews which are available on PubMed. And I'll just go through quickly through this paper. So what initially they say, they have defined osteomyelitis is an inflammation of bone, usually due to infection with bacteria or other microorganisms, very rarely fungus, that is associated with bone destruction. Whereas septic arthritis is an infection of the synovial space that involves the synovial membrane, the joint, and the structures of the joint, mainly the cartilage, the bone, and the covering or the capsule of the joint. So what are the routes of inoculation? The routes of most common is hematogenous. It can happen with URTI or skin infections or any invasive procedures. There are other causes of inoculation such as direct inoculation or contiguous spread. So the destructive anatomical characteristic of younger children, especially the presence of vessels between the metaphysis and epiphysis and intracapsular metaphysis, involve that a bone infection may lead to a septic arthritis secondary to osteomyelitis or a vice versa. So sometimes you see the septic arthritis first followed by osteomyelitis, but sometimes the picture is completely ulta and you see osteomyelitis first, which goes to which crosses the epiphysis, and then it's a septic joint. So what is the pathogenesis of septic arthritis? So bacteria are deposited in the synovium, producing inflammation and proteolytic enzymes. They spread in the synovial fluid and multiply, and they create more and more inflammation, and thus the joint becomes swollen and painful. And once the destruction starts, the sequelae is setting. So the main difference between a septic arthritis in infant and in children, that in infant it will destroy the cartilage because the bone is more of a cartilaginous. It is not still completely grown up. Whereas in older children or adolescents, the bone is already there, but it undergoes ischemia. And because of this ischemia, they go into necrosis, and thus the development of the bone does not occur well, which can lead to AVN and the epiphyseal growth closure also. So like I said, there is release of proteolytic enzyme bacteria, and these can damage within 8 hours. So we have to be very, very vigilant, very, very quick in deciding whether the osteomyelitis or septic arthritis is setting in. And if it is so, you have to act quickly, do some investigations, prove that it is osteomyelitis or septic arthritis, and go ahead and start the treatment. Either it could be medical line of treatment or a surgical line of treatment. That depends upon the severity of the inflammation and infection. My slides are not moving. Hello? Am I audible?
Sir, yes, sir. You are audible, sir.
Yes, yes.
My slides are, I'll just unshare and then share again. Yeah. So reaction that is often associated with Septic arthritis or osteomyelitis has the potential to destroy structures such as articular cartilage and epiphyseal growth plate, resulting in long-term disability due to functional impairment of the joint or to the limb asymmetry. So what this paper has been divided into two parts. First part is a septic arthritis, and they have reviewed all the parameters. And so we'll just start with septic arthritis. There is no specific classification. By the way, we can determine the severity, affection of the septic arthritis. As far as epidemiology is concerned, 1 in 1 lakh babies in industrialized countries and 1 to 1,500 in developing countries. So it is very high in developing countries. The risk factors: younger the child, more likely that the destruction and the further prognosis is going to be worse. And if you have invasive catheterization, host status, if the immunity is low, then the likelihood that the child is going to get infection. Staph aureus is the most commonest agent, but nowadays we are seeing MSSA, MRSA, gas organisms, and group B streptococci also. And sometimes you see Haemophilus influenzae and Kigella kingi organisms also. So clinical presentation in neonates, it is pseudoparalysis and paradoxical irritability. So child refuses to have the feet, have their feeds. Child is not moving the limb, and the simplest test we do for the lower limbs is we just hold the in the axilla and just see if the limb are there. And if the child is holding the limb in flexion, adduction, and internally, ankle also. Simultaneously, you can see the same things in upper limb also. So wherever there are pseudoparalysis, first thing you should suspect is infection. And in older children, infants and toddlers, they refuse they are antalgic in position, and their movements are very, very painful. Coming on to the laboratory markers, sorry. Yeah. Coming on to the laboratory markers, the WBC count is more than 12,000. CRP is always high. ESR is also high, more than 40 mm per hour in septic arthritis and osteomyelitis. And PCT is also high, which is a diagnostic value. So generally, we don't do PT quite often, but we rely mostly on WBC and CRP count. Ultrasound is the most useful and easily available tool to determine the joint effusion. X-rays are mandatory to exclude other conditions. MRI is highly sensitive and specific. Sorry, I'm again not able to move my slides. Yeah. So like through quickly. So methods of diagnosis is X-ray, often seen in late presentation. Joints are already destructed. There is metaphyseal widening and periosteal reaction seen on X-rays. Ultrasound, like I said, they are very, very sensitive and specific also. They will show you fluid, pus, septae. they will show you the ossific nucleus or the bone. If there is a periosteal elevation, that can be easily picked up on ultrasound. And in cases of hip, if they are dislocated after septic hip, it can be visualized also. Of course, MRI is the treatment modality or diagnosis investigation of choice to rule out osteomyelitis and septic arthritis. So, coming on to the microbiological investigations, joint aspiration is sometimes done, and once you have the joint aspiration, you send that fluid for culture and as well as for histopath also. So antibiotic therapy is started, and once we have the cultures, then we can start with the selected IV antibiotics. So generally the rule is you give IV antibiotics for 2 to 4 days. Sometimes you extend that to 1 week, and in some severe cases you go up to 2 weeks also, followed by oral antibiotics for 6 weeks. Surgical therapy should be adopted in cases of frankly purulent fluid or diagnostic aspiration, absence of response to antibiotic, and late presentation cases. So there is, however, insufficient evidence to make treatment recommendations at the present, and long-term safety data and the determinants of the optimum route, dose, and timing of corticosteroids are also required. At all times, a septic joint condition should be treated as an emergency, and after finding pus by the diagnostic of needle aspiration, orthotomy or arthroscopic irrigation should be performed immediately. So this is one of the orthopedic emergencies which we consider, and we have to drain the osteomyelitis or septic arthritis immediately as early as possible. I just skip this. Yeah. So the coming on to the prognosis, younger the age, better the prognosis if you drain early. If the trans epiphyseal vessels are crossed, then the prognosis is worst. If there is therapeutic delay, so the studies have shown that excellent results are obtained in 75% of patients treated promptly, and in only 15% of these treated after 4 days from symptoms onset. Causative bacteria, Staph aureus, MRSA are more severe courses, and the deep joints have worse outcomes. Now coming on to osteomyelitis, again there are no specific guidelines for classification of osteomyelitis, which are dependent on bone involvement or antimicrobial resistance patterns. So we do not have a classification for osteomyelitis as well as the septic arthritis. As far as the epidemiology goes, you see almost 43 in 1 lakh cases in Polynesia group age group, and 200 in 1 lakh cases in aboriginal population. So that is the developing countries. The incidence of osteomyelitis is very high. So coming on to the risk factors and causative organisms, systemic infections, prenatal trauma, risk factors are not found in nearly 50% of the cases. Staph aureus is the most common pathogen, but the incidence of MRSA is rising. H. influenzae must be suspected in non-immunized children. Kigella kingi is becoming one of the most common gram-negative causative pathogens and must be suspected in younger children. So you should be more vigilant on the clinical presentation, and local signs and symptoms are most common clinical elements. 40% of these children can be afebrile. So even if they are afebrile, but the local signs and symptoms are showing you the way of osteomyelitis, then you should clinically suspect, investigate further. So laboratory markers we have already discussed. Imaging is almost similar to the osteomyelitis. So I'll just go quickly through that. Even an antibiotic course is also similar. A short course of IV antibiotics followed by 3 weeks of oral antibiotics is generally recommended in osteomyelitis. Continued pain, localized erythema, and swelling despite initial treatment, and the presence of abscess or osseous destruction with imaging is the indication for surgical drainage. So to come to conclusion, younger the child, worse is the prognosis. Septic arthritis and osteomyelitis together give worse results. Delay in surgery gives worse results. Sometimes you see DVT with septic arthritis and it can be missed out. Long-term follow-up is required in these children. Early diagnosis and aggressive treatment gives best results. Ultrasound is a reliable method for diagnosis. Empirical antibiotic of choice is vancomycin and amikacin. Vancomycin and amikacin is the drug of choice in negative culture report. All patients with poor results had delayed presentation and preoperative radiographic changes. So before it is too late, we should act fast and prevent the sequelae of osteomyelitis and septic arthritis. So this is a similar case with the osteomyelitis with a non-union of neck femur with short femur and a small head with varus neck shaft angle. We had to treat it with a bone graft, reconstruction of the femoral head, and a valgus osteotomy to correct the hip deformity and to get the union at the non-union site. Thank you very much.
Thank you, sir. Excellent. So I have one doubt, especially neonatal. One second, I'll just on my video. So in neonatal septic arthritis, many times after 2 to 3, rather 4 days of antibiotics, baby starts moving the joints. So that time compliance for IV antibiotic therapy really a big question. So in neonate, whether it is advisable to shift or to oral antibiotics after 4-5 days.
No, you have to, if so, there is a dictum that if there is a pus, you have to drain the pus. And once you have drained the pus, then you continue the antibiotics to prevent further destruction because of the pus and to prevent further destruction of the bone. So first you have to decompress the joint. That is the most important thing. So once you decompress, the things will become, I can say that 70-80% things will become all right at that point only. But further prevention and worsening of the disease can be taken care of by further antibiotics. So generally we recommend
that also 6 weeks.
So generally we advise 2 weeks of IV antibiotics followed by 6 weeks of 3 to 4 weeks of oral antibiotics.
Okay. Okay.
So
thank you.
Just before coming here, I just did a septic ankle with a calcaneal involvement of one of our colleagues only. So this child was like now 3-4 days already delayed, and he has got infection of calcaneum. And as we know that calcaneum is a bone with lot of joints around, and it's a soft bone. So likely that destruction of calcaneum to happen, likely that the subtalar and the talar joint or the ankle joint involvement in this child is going to be very high. So
what is the age for
3 years?
Okay. Growing.
So, yeah. So if we treat and diagnose it early, we will be able to manage the sequelae much better way.
Yeah. Okay. Fine. Thank you.
Yep.
Any more questions?
I think no questions.
Yeah,
Very
no questions.
So thanks, Amar.
Yeah.
Thank you, madam.
Yeah. It was nice presentation, Raju.
Thank you. Thank you.
Yeah.
Thank you, Amar and Rajeev.
Yeah. Thank you, madam.
Amar joined. I Amar
चला दिसतंय Amar.
Okay.
चला.
Thank you, ma'am.